Jonathan's going to finish up our symposium and talk to us about ALIF and OLIF and the tragedies that underlie those on occasion.
Yeah. The tragedies that befall us. Yes. Thank you for letting me speak. I know we're probably a little bit behind on time. I'm going to try to kind of fly through this and hopefully leave some key takeaways in the interest of disclosures. To begin, a few quick words on ATP procedures. Despite the fact that they share a name, I really think we have to stress the fact that when we talk about ATPs, OLIF, what have you, they're really two distinct procedures combined into one with huge utility as the end result. But really the anatomic relationship at L5 is what becomes imperative and critical to recognize for the conversation as it applies to complications here. Really, the addition of the 5-1 level has been an incredibly powerful tool in the ATP space, but we always have to recognize that it's also introduced back into the conversation the risk of major vascular injury. It is truly a formal vascular dissection incorporated into an anterior spinal procedure. So when we talk about complications specifically, sorry, having some technical difficulties. If we take a second kind of pause and consider, sort of each of our own worst case scenarios in the OR, if it involves the anterolateral space, but it doesn't involve massive hemorrhage, I would applaud you. I'd say kudos. And so here I don't want to minimize any of the other complications listed, but to me, in my practice, major vascular injury is what I lose the most sleep over. So my goal here is to discuss major vascular injuries in the context of both ALIF and ATP approaches, including when they happen, why they happen, how to avoid them, but equally important, how to manage a major vascular injury in the event that it does occur. I'm going to really focus in on endovascular treatment options, and this may seem to shift away from traditional vascular teachings, but it's proven quite successful in my practice and anecdotally in others. I don't want to spend too much time on anatomy other than to say having a healthy understanding and probably respect with your surroundings becomes that much more critical in both ALIFs and ATP approaches relative to, say, a direct lateral approach. Because, here soft tissue and vascular implications are ever present. That being said, I think procedural education and training can really readily overcome any early experience limitations in this setting. Jumping ahead, I think the etiology of major vascular injuries can be well explained with the 5 Ws. Who doesn't matter so much to me. We all have a responsibility here. Pretty simple, arterial versus venous. I'm going to focus in on major venous injuries for the rest of this conversation because they tend to be most disastrous. Now, when can really occur at any time in the operation. I see 3 major opportunities, though. During the initial retroperitoneal dissection, obviously, vascular injury can occur, and that's probably a really good time to consider abandoning ship. My goal here is to identify these high-risk scenarios, these at-risk patients ahead of time before we get into the OR, and have a very clear and discrete conversation with the patient about the potential implications, whether they have high-risk vascular anatomy or high-risk patient factors like high BMI, what have you. But then in the event that we get in there, we have agreed upon a plan and unfortunately have to abandon the operation due to a major vascular complication. It's not a total blindside or surprise afterwards. The next place injury can occur, obviously, during disc prep. I think this creates a bit of a dilemma, and you have to consider where you're at in the spine portion of the procedure and a question of can you actually complete it safely. From my standpoint, I try to always avoid any kind of immediate or primary repair at this point because if I do engage in a primary repair method, there's really no way I'm going to go and retract that vessel again in an attempt to complete the operation. I've done it. I would discourage it. So if a topical hemostatic and direct pressure with a manual retractor can accomplish bleeding control, then it may be reasonable to consider proceeding and completing the spine operation, then come back and formally repair that vessel at that point. Finally, if injury occurs during interbody placement, this may be the best case scenario, I guess, where, leave the interbody in place, pack with hemostatics, ideally come back to fight another day. The sort of where and why piece of the conversation I think is actually most important, and they really go hand in hand. I find that most often, for the same reason the injury occurs, is the same reason that conventional vascular techniques, repair, or even ligation are probably going to be quite difficult, if not impossible. These injuries typically are back wall venous injuries that occur in the context of a severely adherent vessel that you've spent a whole lot of time, hopefully, mobilizing already, but you're struggling. And now the idea that you're going to get in there and just put a stitch in it, I think becomes rather impractical. And that's what really led me down the endovascular path in an effort to really find a better strategy for managing these injuries. I agree that life supersedes limb in the context of these situations, but I think you got to rewind and consider why you're there in the first place, right? It's not because of a trauma, it's not because of a ruptured aneurysm or something, it's because of elective spine surgery. So taking a look at major venous injury in the context of the literature, it's first really important to define that as a whole, and then really there's a couple key takeaways that I think exist in the literature. First off, in the context of highly experienced spinal access surgeons, venous injury in the ALIF setting should be rare, roughly 1.8% of the time in experienced surgeons' hands. Additionally, I think it's important to point out that it's widely understood and accepted that the 4 or 5 level, when that's included in the construct, that's where you see that big bump, and it makes sense just with venous orientation relative to the spine. In the ATP literature, when Rick Hines and Kamal Woods first reported their experience back in 2017, they actually reported a 2.9% incidence of major vascular injury. But if you really scrutinize those numbers, you'll see that all those injuries, there are 4 of them, occurred at the 5-1 level. All were venous. So if you go and exclude the 2-5 only cohort, it actually bumps that number from 2.9% to 4.3%, which even in their series, their ALIF cohort was 3.3, OLIF at 5-1 was 4.3. So it actually exceeded the number seen in ALIF. And I think the takeaway goes back to my earlier comments. This is a fundamentally different procedure at the 5-1 level because we're now introducing the risk of major vascular complications. Any number of further studies have reported varied rates of vascular injury in the literature. So the most critical step to me in my practice in terms of avoidance occurs preoperatively. Pre-op imaging review weighs really heavily on my approach recommendations. My approach to pre-op imaging review is, at least in my mind, kind of simple. First, I'll scroll through axial MRI to develop sort of a mental picture, a roadmap, if you will, of how the vessels relate to the spine at each individual level. I want to kind of take a right turn here and make a quick comment about lateral positioning that sometimes I think gets lost in translation. We talk a lot about, contents falling away, et cetera, et cetera. But in addition to the abdominal contents shifting rightward, so too do all the vessels at all the levels. So gravity is not selective, as we all know, and so 4-5, those vessels shifting rightward can really open up that corridor, as we've seen. But consider at 5-1, the left common iliac vein still shifts medially rightward and can actually obscure view there. So it becomes kind of spatially disorienting at times. I think that's just an important consideration to maintain. So once I've looked at that sort of roadmap, I then will look at level-specific vascular anatomy, considering the affected or disease levels that I need to approach. In this particular case here, when I look at 5-1, I've got a wide open corridor. 4-5, I'd say, looks pretty narrow. So my thought process here is, if I consider at 4-5, standard ALIF, I'm working towards those vessels and relocating left common iliac vein all the way across. It looks a little bit prohibitive just with that big overriding psoas. You've got veins kind of occupying the entire central disc space. So then I look down at 5-1, got a wide open corridor there. So to me, either ATP or ALIF approach is possible at that level. So putting it all together, if it were up to me, I'd say an ATP approach is quite favorable here because I have so much more wiggle room in an anti-psoas approach at that 4-5. I'm not taking down perforators. I'm not having to mobilize that iliac vein. So I'll take that any day, and then 5-1 becomes really additive, at least in my hands. Avoidance really is obviously the mainstay of my practice and my hemorrhage algorithm. To take this a step further, though, I think in the context of single position, single surgeon approaches, where experience may be limited just due to the novelty of the ATP approach itself, we really need an effective and objective strategy for planning. And Chung and colleagues published their single center experience using this proposed classification scheme specifically in the context of 5-1 ATP procedures. Although conceptually I think this applies to ALIFs as well, and we need more validation of these types of tools. So the bottom line is this. If you do enough of these procedures, there will likely come a time where avoidance is no longer really possible, and we have to consider management strategies. I think a very clear understanding of vascular anatomy that recognizes potential pitfalls based on either approach related to vascular injury is a complete necessity. I guess simply put, statistically, the highest risk of venous injury in the ALIF setting is at the 4-5 level. In the ATP setting, I would submit that it's at the 5-1 level. So we have to pair that information together to make decisions. So moving on quickly to sort of a brief management algorithm. Remember, this is, venous system's a low pressure but extremely high flow system. So direct pressure is the first and immediate step in terms of treating this. Adding in a topical and then of course, giving it time to actually be effective is important. This is where experience kind of can weigh in, being able to kind of recognize flow volume or a size of tear that's probably not going to respond to topicals. And then this is also a great time to phone a friend, be it IR or vascular surgery, who's close by, hopefully, to come in and give a hand. Certainly before attempting any kind of primary repair. Also consider whether further exposure is necessary, especially in the lateral position. Always in the back of your mind, consider going supine. That's going to be a more approachable access point for a vascular surgeon, as well as for any endovascular management strategy. So a brief word on a couple key items. I think from a topical hemostatic standpoint, I know there's always an abundance of flow seal, Surgiflow in the room. There never seems to be a lack for that. But I really personally discourage the use around major vessel injuries because of the potential or propensity for that to inspissate into the vessel and actually propagate a clot. So I really prefer to use Surgicel Snow, which is kind of advanced on fibular, as kind of my first line therapy. But this Everest, if you take a picture of anything, and if you're not familiar with it, this is a game changer from my standpoint. It's the most potent topical hemostatic that I'm aware of, sort of a combo, fibrin, thrombin, woven, et cetera. And the 3 times I've had to use it, all 3 of those patients went home just fine. So I would keep it available for sure. As far as energy devices go, again, a dealer's choice here. I favor Aquamanus, but at the end of the day, any option's fine. You just need to have something that's long and narrow to fit in a hole, but also not obscure view. As far as direct repair tools, particularly in the MI spine space, again, we got to consider things other than a traditional needle driver or Castro Viejo, because they're not going to reach in these deep, dark holes. So I use a set of thoracoscopic needle drivers and always have a laparoscopic knot pusher available. So that's getting to, all these steps lead up to endovascular management, which I've alluded to this already, but it's really become a constant in my hemorrhage management algorithm. It's crucial, though, to identify these resources ahead of time. Having a conversation with an IR doc and or a vascular surgeon that's local to you really helps if you do it ahead of time before disaster strikes. And it's important that everyone's on the same page. So timing becomes imperative when considering this type of intervention. The decision has to be made very early on, before massive hemorrhage and definitely before coagulopathy sets in. I always prep in bilateral groins for all my patients regardless of position, so that bilateral groin access becomes really readily accessible. If you have that and you can get access to the veins, put wires up, balloon occlusion buys you time to actually evaluate the injury. But here again, primary repair, I would tend to discourage if you've already gone down this path, because it's probably a big hole that's not going to do well with suture. So this engages a conversation of covered versus uncovered stents. That's a whole nother probably day-long lecture. But I will say this, the literature, there's a real paucity of data to support this practice. At the same time, I agree with these authors' conclusion out of West Virginia that this has really become my primary modality of repair in these complex injuries. I'm going to jump forward and try to summarize ever so briefly, simply to say, I think with proper procedural selection and pre-op planning, patients ultimately do better. I think this requires more collaboration between experienced spinal surgeons, spinal access surgeons, regardless of approach. We have to also focus much more on objective screening criteria and never lose sight of the fact that all these procedures have value in the right context. At the end of the day, though, I think there's no substitute for experience, but I think taking into consideration some of these thoughts and, again, this educational piece may bridge some of that gap. Again, as Ben Franklin said it, hope for the best, plan for the worst. Thank you.
Thanks.